Well, good afternoon or early evening, depending on where you are. I'm Jim Boyer. I'm a hepatologist at Yale School of Medicine, and I'm joined today by a doctor. Can you pronounce your name correctly for me?
Yeah,
Trivedi.
yeah.
Big.
Trivedi, yes, yeah. Palak
Trivedi.
Trivedi, yeah.
Yeah, sorry about that. And we're here to discuss the recent developments in primary biliary cholangitis, a orphan disease, but an important disease of which there have been several significant therapeutic developments that we'll get into in a few minutes. So I'll start off asking some of the questions here. And the first question is, what are the current diagnostic criteria and methods used for early diagnosis of PBC? Have there been any recent developments or advances with a greater need for uptake?
Very good question. Thank you, Professor Boyer. So I think when we talk about diagnostic criteria for PBC, we have to have a high index of suspicion. And most people who present with PBC in the current era, we acknowledge and recognize are going to be women above the age of 45, above the age of 50 years old, who have cholestatic biochemistry, elevated alkaline phosphatase and gamma GT values. And that is the lion's share of the cohort that we see. And when we see that biochemical profile, particularly in somebody of that phenotype, we start looking for autoantibodies, principally anti-mitochondrial antibodies, AMA. And the combination of anti-mitochondrial antibodies and cholestatic biochemistry is now sufficient, according to all contemporary guidelines, to make a diagnosis, provided there is no other factors screaming out at you that this is going to be another disease entity. I think when it comes to recent diagnostic advances, I mean, they're no longer recent, but in the last 10 years, there's an increasing appreciation of PBC-specific anti-nuclear antibodies, such as anti-GP210 and anti-SP100. And we also recognize that there is a stronger association with other non-PBC-specific antibodies, such as anti-centromere, because of the association with scleroderma and Raynaud's phenomenon, which does occur in people with PBC more commonly than it does in the general population. It's rare and uncommon that we need to perform a liver biopsy for diagnostic purposes, and liver biopsies now should not be performed for diagnostic purposes unless there is, of course, diagnostic doubt. But principally, it's going to be a combination of PBC-specific anti-mitochondrial antibodies and or PBC anti-nuclear antibodies together with cholestatic biochemistry, most often in women above the age of 45 to 50, but appreciating that we can sometimes see people outside of that spectrum.
Now, what about staging the disease? Because in the past, certainly when I was practicing in earlier periods, we often almost always did a liver biopsy for the diagnosis. We don't do that anymore. But so what's the best way of staging the disease?
Yeah, that's an excellent. Yeah, I mean, that's an excellent point. And I do think liver biopsy still in 2024 carries an invaluable piece of information, because as when you stage somebody's liver with sort of PBC, and in parallel, you grade the severity of liver injury based on inflammation, based on biliary features, based on the presence or absence of ductopenia and cholestasis. And stage is often used as interchangeably with fibrosis. And certainly that is a principal covariate associated with long-term outcome. The more fibrosis a person's liver carries, the more likely they are to reach a clinical event in their lifetime. But with the contemporary technologies, principally transient elastography, or colloquially known as FibroScan, there is no longer a need to biopsy the liver to stage the degree of fibrosis in somebody with PBC. And then there is now robustly validated through several international multi-center cohorts studies the utility of FibroScan in prognosticating people's outcome, but also in staging the degree of fibrosis that somebody carries. However, as yet, there are no clinical grade markers to look at the degree of ductopenia, cholate stasis, and portal inflammation, which may also carry additional value. So in some circumstances, the exception rather than the rule, biopsy may still be performed to look at those parameters.
Very good. Do you want to ask the next question here?
Yes, of course. So in June 2024 is an exciting month for the PBC community. On the 10th, we saw approval of Elafibranor. This is one of the first new therapies in a long while for the treatment of PBC. So, Professor Boyer, I mean, in your opinion, how have new therapies changed discussions around management of PBC? And secondly, what's the outlook on the potential impact of new therapies in coming years, including but not limited to Seladelpar?
Yeah, very good questions. And it's an exciting time right now because we have some new therapies that clearly have changed the landscape in terms of efficacy and improvement of symptoms. But let me go back just a little bit to indicate that the standard of care up until recently was ursodeoxycholic acid for this disease. But about 40%, anywhere from 35-40% of patients don't respond completely or don't respond with dropping the alkaline phosphatase, which, by the way, is a significant prognostic marker in PBC. The higher it is, the more adverse the ultimate prognosis in terms of transplant and death. So several years ago, the FDA approved another drug called obeticholic acid, or Oclivia, and that is a derivative of a bile acid, of chenodeoxycholic acid, one of our primary bile acids. And it's a potent FXR nuclear receptor agonist, and it has had now about more than 5 years, I think, and maybe even longer now in clinical practice as the second-line drug for treatment. Now, the problem with Oclivia or Oclivia is that it has significant side effects in terms of pruritus, itching, and this is one of the difficulties with the drug. It also increases your serum cholesterol, LDL cholesterol, and so not only that, but only about a little less than half of the patients in the initial trial, so-called POISE trial, met the primary endpoints for the trial, and that means that there's a continuing unmet need for further therapies. There are two drugs that completed phase 3 trials recently. Elafibranor was the first one, and it just was approved by the FDA as a second-line therapy. And the other one is Seladelpar, as you mentioned, and that is, I'm sure will be approved fairly shortly. These two drugs are nuclear receptor agonists. They an alpha, delta, and gamma agonist. Nuclear receptor, and the drugs differ in their activity to these nuclear receptors, with Elafibranor being an alpha delta agonist and Seladelpar being a pure delta agonist. Now, whether there's a difference in those different formulations of these PPR agonists, nuclear receptor agonists, I'm not clear, and I'm not sure anybody is really clear. But the exciting thing is with both Elafibranor and Seladelpar, they met the primary endpoints after a year's trial and phase 3 trial. Elafibranor, I think, came in at, I always have to look these figures up. Can't keep them in my head at my age. Excuse me. At 51% met the primary endpoint, which was the composite endpoint that was used in the POISE trial for obeticholic acid. That's the criteria there, the significant reduction in the alkaline phosphatase below 1.67 upper limits of normal, at least 15% or more of a reduction in total alkaline phosphatase, and a normal serum bilirubin. Those are the criteria that were the primary endpoints in both these trials, all three of these trials. The primary endpoint was met in 51% with the Elafibranor, with a placebo group of 4%, And Seladelpar, surprisingly, had a slightly elevated primary endpoint of 61.7%, but their placebo group was 20%, which is surprising. And I'm not sure quite what that means, whether we're on some kind of other therapy or not. But when you subtract the placebo group, they really have about the same. They're very equivalent, I think, at least in my mind, in terms of their efficacy. And of course, that exceeds the data from obeticholic acid, where I think 47% met primary endpoint with a 10% placebo group. So if you subtract those placebo groups, you can see both these drugs are a significant improvement. They also improve pruritus, the itching, quality of life measurements, and with Seladelpar having a slight edge there in terms of the scoring system for itching. But I think as time goes on, we'll learn whether there's really any difference there between effectiveness of pruritus in the long run. So that's about it. Good news for patients with PBC.
In addition to the primary endpoint, did you want to briefly comment about the rates of and importance of alkaline phosphatase normalization? Because that's something that, as an emerging treatment consideration in this group of patients.
Mm-hmm. Absolutely. For obeticholic acid, I think it was, well, I don't have that figure here. It's not on top of my head, but normalization for Elafibranor was 15%. Normalization for Seladelpar was 25% after a year of therapy. Obeticholic acid, I think, was down around
4% or something. It was very much lower. Yes, yeah. So absolutely. So these therapies sort of are seem to be hitting a higher bar, which is excellent for patients.
Yeah. So that's exciting. So let's maybe move to the third question. I can ask, what are the major unmet needs in the current management of PBC from both a clinical and patient perspective?
Yeah, so I mean, and I think it dovetails nicely from what we were just talking about regarding alkaline phosphatase values. I mean, I think from a clinical perspective, what we want to do for all our patients is give them a longer life and a better life. And when it comes to a longer life, as you alluded to, the lower the alkaline phosphatase, the more likely that's going to be achievable. And we want to aim for as low an alkaline phosphatase as possible, ideally normal for the vast majority of individuals. Now, these newer drugs are a step towards normalization, but the vast majority of people still, at least over a year, over 2 years, have not reached that endpoint. Now, we hope that over time, the longer we use these therapies, and the longer people stay on them, the greater the proportion of people who attain that goal is. But we are still waiting for those therapies that attain very high bars of alkaline phosphatase normalization in the 60, 65, 70% range. That's what we really want. And it may be that we have to combine therapies such as Seladelpar and Elafibranor with existing agents such as obeticholic acid or other agents that are emerging. So I think aiming for normalization, we are getting there, but I think that's a long way to go. And we need to have good therapies that demonstrate the ability to induce fibrosis regression, or at least stability in fibrosis, because that is what determines clinical endpoints for people. And from the patient point of view, it's great that, as you alluded to, these new agents are able to improve pruritus severity or intensity, should I say, for our patients, which is a big determinant of quality of life. But we are currently lacking therapies in PBC and cholestatic diseases that improve other elements such as cognitive impairment, cognitive dysfunction, fatigue associated with cholestasis. And I think having new therapies that really hit those, very important, equally important, should I say, determinants of poor quality of life in our patients is still an aspiration that we have not yet managed to reach with current therapies. And I'm hoping that as we start to build in health-related quality of life tools and patient-reported outcome measures within efficacy trials to a greater degree, that goal will become closer and closer.
Are you excited about any other therapies that are in development?
So I think from an itch point of view, I'm quite excited to see how these new agents, these next generation PPAR agonists, compare to apical sodium bile acid transporter inhibitors, for example. So, or ileol bile acid transporter inhibitors. Now, they have been licensed for the treatment of genetic disorders of cholestasis, or congenital disorders of cholestasis, such as Alagille syndrome, and they have been and are under clinical trial for people with PBC and PSC. So I'm excited about those agents to see how those particular tools are able to attenuate cholestasis. And I'm also sort of interested to see how newer agents that such as that act on sort of steroid inhibition improve cognitive impairment and fatigue associated with PBC. I mean, these are almost like first-in-class agents when it comes to the treatment of cognitive impairment and brain fog in PBC patients. So those are the ones that I'm very much keen on exploring further.
Well, I think today there were some preliminary results that were released for one of the IBAT inhibitors, and, and that had a significant effect on the Pruritus scales, and that looked very impressive. And also, I think fatigue. Fatigue was also apparently improved, but this is just a press release, so we have to wait till see more data. But I'm very high on the pathogenesis of these drugs because they lower the bile acid pool size. That's the major mechanism by blocking the reabsorption in the terminal ileum. And so, initially bile acid synthesis increases because of the feedback regulation of the bile acid metabolism, but then the bile acid pool size is lowered. And when that happens, I think the initial stimulus or inflammatory injury in the liver is diminished. So we'll have to watch that very, very carefully. And of course, there are other PPR, as you allude to, agonists out there, and we didn't mention enzafibrate, but which also has data very similar to the promising data we talked about earlier. Right.
Yeah, absolutely. And so, I mean, we've talked a lot about symptoms in the last few minutes, and may I just finish off by just asking you, as you and I, as healthcare providers and our fellow colleagues, how can we better support patients with PBC in managing their conditions? How can we empower them to and support them to better manage their PBC?
Well, first of all, I think we have to realize that a lot of patients out there are not diagnosed, particularly in primary care situations. And we need to do a lot more to make the primary care physicians aware of this disease and how to ask for an anti-mitochondrial antibody when they see a middle-aged woman, particularly with an elevated alk-phos. And so a real campaign, I think, such as you have in England for this condition, we need to do a better job of that in the United States, I think, than we have. We need to pay attention to the side effects issues, of course, the itching, treat that adequately, not let that. You have to ask the patients, are they itching, and is it keeping you up at night, and do you have excoriations on your body from the itching? To get an idea how severe these symptoms are and whether they're being adequately treated. I think both urso and these IBAT inhibitors, I think, are going to come along and help with this symptom. But we need to pay attention. The physician in the office needs to ask specifically whether the patient in front of them is having these symptoms.
Absolutely, and I think there was some exciting data presented at the recent International Liver Congress in Milan a few weeks ago, where a group in the Netherlands, as part of the global PBC group, have actually created a patient-facing document, like a question prompt list. So, how can you get the most out of your consultation with your doctor? How can you enable the best value-based healthcare when you have PBC, and a very simple 10-point checklist that people can carry with them to say, these are the things that my doctor needs to tell me, and they most of them, if not all of them, sort of very nice mirror and overlap with what you just said, Professor Boyer. So it is a very exciting time to work in PBC. Yeah.
Absolutely.
Great. Good.
Any final remarks? Oh,
I think this has been a sort of a very sort of stimulating discussion. It's I'd like to thank you very much for this enlightening conversation. I'm sure our audience members will really appreciate all the insights here today in our brief discussion. And before concluding, I just wanted to extend a thank you to our audience for listening to this HCPLive special report. And I wish everybody a sort of good morning, good afternoon, and good evening wherever you are. Thank you. Goodbye.
Very much.